Hello everybody, and welcome to our webinar on the surgical management of pediatric epilepsy. This is Gretchen Von Allmen. I'm the director of the Pediatric Epilepsy Program here at Children's Memorial Hermann and UT Health. And with me today are Dr. Manish Shah and Dr. Nitin Tandon, both neurosurgeons in our epilepsy program. And we're going to start off by each of us giving part of this presentation. I'll go first, and then Dr. Shah will follow, and then Dr. Tandon. And we'll have a period at the end for questions. So at any point in the webinar, you can go ahead and post your questions on the chat, and then during the question and answer session at the end, we'll answer those. And so at any point, you can go ahead and post questions. So I'm going to go ahead and get started. So just an overview of what we'll be talking about today. We'll just kind of tell you a little bit about Children's Memorial Hermann Hospital, which is where our program is, and then I will discuss intractable epilepsy, what that means, and how we evaluate that problem here at Hermann and UT, and what kind of evaluation is usually done, what the options are, and what we have available here. And then what treatments are available for pediatric patients who have difficult to control epilepsy, and contact information for everybody. So this is Children's Memorial Hermann here in the Texas Medical Center, and here we are located in Houston, Texas. That's me, and I won't go into any details, but just go ahead and start telling you about epilepsy. So this is from a report that came out from the Institute of Medicine, which is in Washington, D.C., and was a big project to evaluate the epidemiology of epilepsy, and really kind of to bring things up to date about what's happening in the United States for people who have epilepsy. So the findings were that there are 2.2 million people in the United States with epilepsy. This is in 2012, and about 150,000 new cases each year that are diagnosed. You can see from this graph that there are mostly children early in life, below the age of 15, who are being diagnosed with epilepsy, and then later on in life, as people get older, the incidence of epilepsy increases as well. So epilepsy in children is quite a big problem, and in general, it's one of the more prevalent neurological diseases that people deal with, and 1 in 26 people will develop epilepsy in their lifetimes, which is really a pretty astounding number, and I think it's very helpful that this study was done, because it really brings to the forefront how much of a problem epilepsy really is in the United States. So in terms of epilepsy in Texas, out of all the people in Texas, there are more than 6 million children, almost 7 million children in Texas, and about 1% of those have epilepsy. So that leaves us with almost 70,000 children with epilepsy in the state of Texas. A third of those children, and in general, a third of children with epilepsy really do not respond well to the medications that we have available to treat epilepsy. And so a lot of the children in that population are the type of children that we see in epilepsy programs like ours. So just some simple math, lets us know that there are really about 21,000 children in Texas who are not well controlled with medications for epilepsy. I think one of the important messages that we try to get out there as a program, and that all pediatric neurology and neurosurgery programs try to make people aware of, is that epilepsy surgery is a very effective treatment for children who do not respond to medications. And so we really feel that evaluation for intractable epilepsy in a center that can provide epilepsy surgery is very important for those children. And so we try to get children evaluated as quickly as possible in our program. And just to kind of underline that, the average length of time found in this Institute of Medicine study between the onset of seizures to having surgery in patients who were candidates was found to be 17 to 23 years. So that's a really long time to have epilepsy that's not controlled if you should be a surgical candidate. And something that even adds more urgency to that is that the children who have uncontrolled convulsions or generalized tonic-clonic seizures who are surgical candidates are in the highest risk group for having SUDEP, which is sudden unexplained death in epilepsy. So this is just kind of to review what I've just told you. About a third of children who have epilepsy are not going to respond to medications, or at least by having really good seizure control with just medications. And the length of time between seizure onset and surgery is 17 to 23 years right now in the United States. And this kind of more and more well-known problem of sudden unexplained death in epilepsy, or sudden unexpected death in epilepsy, happens to 1 in 10,000 people who are newly diagnosed with epilepsy, and in 9 out of 1,000 candidates for epilepsy surgeries. So that being said, the best treatment for epilepsy is still the medications that we have available, which are called anticonvulsant medications. And an anticonvulsant medication is a medicine that's taken every day to prevent seizures in people who have epilepsy. There are many different types of medications that are used for this purpose, more than 20 or 30 at this point. And some of those medications are better for some seizure types. Some of the medications can even make certain seizure types worse. And so really it's important to be evaluated by an epilepsy specialist or a pediatric neurologist who can help choose what type of medication for epilepsy is going to work best for each particular child. And that really is dependent on proper diagnosis of the seizure types and the epilepsy syndromes. And we have several ways that we do that here at UT and Children's Memorial Hermann. The goal of treatment with medications is really the same goal of any of our treatments for epilepsy, which is, number one, that the child does not have any seizures on treatment, and we want them to not suffer from side effects or have as few side effects from medications as possible. So how effective are these medications that we have right now to use for epilepsy? This graph just kind of shows you how many patients typically respond to the first medication, about 47% of them, and then another 13% will become seizure-free after a second medication is tried. And then as you get further and further down medication trials, there are less and less patients who are going to respond if they haven't responded to the first or second medicine. So then that leaves 36% of children with epilepsy who are not responding to medications and multiple medications. So what is refractory or intractable epilepsy? As I've said, 2/3 of kids are going to respond well to the medications we have available, and depending on their seizure types and seizure syndrome and other factors about how they're doing, many of them will outgrow their seizures and the need for medication over time. And really all of that, who is really going to be most likely to outgrow the seizures depends on their evaluation and other factors that we would go over in the epilepsy clinic. So once a child has gone through 2 or 3 medications for seizures that are the proper type of medication to use for them and their seizure types and at the proper doses, after that point, the chance that they're going to become seizure-free with other medications is less than 2%. And that's the population that we call intractable. So the problem with intractable epilepsy, other than the risk of the sudden unexplained death in epilepsy, as we discussed before, the other problem is that in children who are trying to develop cognitively, socially, physically, these seizures that occur without being controlled have a detrimental effect on their development and on their quality of life and their ability to grow up as they should without seizures. And really our goal is to try to control these seizures as soon as possible when a child is diagnosed with epilepsy so that we can optimize their development and they can reach their full potential, whatever that potential may be, in terms of their physical and emotional and language development and their quality of life. That being said, just because children are in a special part of their life, they're growing and developing constantly, they really are quite different to treat than adults who have epilepsy. And so most medical professionals agree that there really should be special pediatric epilepsy surgery centers to treat these children so that they can be treated by people who have pediatric epilepsy expertise and not just be seen in adult epilepsy centers only. I won't go into a lot of these details, but you can always go back and look at this webinar later on. But the problems that happen when children have uncontrolled seizures early in life result in a lot of changes to the brain and how the brain works. And some of these changes can really make surgery more complicated and the evaluation more complicated in children. And so we really need to know a lot about the type of epilepsy and how the child's brain is working before we can decide what treatments are best for each particular child. Unlike adults, seizures that arise from outside the temporal lobes is much more common, unlike in adults where temporal lobe epilepsy is the most common area of the brain for seizures to arise. And a lot of the times when surgery is done, the pathological finding that comes back when we study the brain tissue that's removed is called cortical dysplasia. And I won't go into a lot of details about that right now, but a lot of the pediatric epilepsy programs see a lot of this particular type of pathology, and sometimes this particular cause of epilepsy can't be really well seen on the MRI, which is why we have a lot of other tools to decide where epilepsy is coming from in the brain. And children can be especially tricky in that sometimes they can have seizures that look like they're coming from the entire brain when actually they're starting from one particular area, which could make them a candidate for surgery. And so a lot of different types of tests often have to be used to decide exactly where seizures are coming from and what particular treatments can be used to help those children. Often children with epilepsy also are going to have problems with their development, problems with their thinking and behavior, and so we really want to get to these children as soon as possible if they need surgery because that can prevent them from having further developmental problems and regression. So basically at our center and at most epilepsy centers, a child is seen in the epilepsy clinic and medications are the first thing that is tried to control epilepsy. Once a child fails to respond to 2 or 3 different medication trials for epilepsy, then they are by definition potential surgical candidates, and so we evaluate them in our specialty center in the hospital at Children's Memorial Hermann, and in particular in the Epilepsy Monitoring Unit. So in the Epilepsy Monitoring Unit, continuous video EEG monitoring is performed, and so electrodes are placed on the child's head. They're kept in a room that has video monitoring. Their parents stay with them, or one parent stays with them. And over a number of days, we capture the typical seizures that the child has, and we can characterize them based on their EEG or brainwave patterns, and also may perform other tests to see exactly what type of epilepsy they have and what is causing the epilepsy. Some of the other tests that might be done in the hospital, either as an outpatient or while the patient is admitted, include PET scan, MEG, which is magnetoencephalography, SPECT scans, and 3T MRI, as well as neuropsychological testing and some other specialized testing as well to see exactly where a child's seizures are coming from, and if that area, if there is one area, can be surgically removed so that the seizures can be treated and stopped. So we call that a pre-surgical evaluation, and really the goals of that type of evaluation, which is usually composed of multiple different types of testing in or outpatient in the hospital, is to decide whether the patient is a good candidate for surgery or resection. And really what we're trying to do is to decide where in the brain the seizures are starting, so localization, and to decide which side of the brain the seizures are coming from, and also to decide where are the important areas of the brain that we really don't want to bother surgically, so the areas that control a child's ability to speak and understand language, their ability to move their body, their ability to perform all the other functions that can be really important for their quality of life, and we certainly don't want to bother those functional areas. So we identify where those functional areas are, and we want to know where those areas are in relation to the part of the brain that's causing the seizures. This can also help us to determine what is the next step. So does the child need invasive monitoring, meaning surgically implanted electrodes, which Dr. Tandon will talk about some more in just a minute. And really our goals of surgery and the goal of performing a pre-surgical evaluation is to reduce the number of seizures that the child has and make them seizure-free if possible, so that that burden is reduced. And then to spare the parts of the brain, the eloquent cortex, that is important for functioning. And also to stop the developmental arrest or regression that's taking place as a result of having uncontrolled seizures, so that we can improve the child's long-term developmental outcome. Some of the other tools that that I briefly mentioned, the Scout video EEG monitoring is done in the hospital in the Epilepsy Monitoring Unit. The 3T MRI is a very detailed MRI picture of the brain that can tell us exactly whether there are areas that did not structurally form correctly. Some of those we can see on MRI, and that helps us to decide whether the patient's a good surgical candidate. And then developmentally targeted neuropsychological testing can also tell us whether there are certain parts of the brain that are not functioning correctly, and often those areas are related to the area of the brain that's generating seizures. And then all of these other alphabet soup type of tests that we do can really help us to see where seizures are coming from without doing an invasive procedure. And then once those tests are done and it's determined that the child is a good candidate for surgery, sometimes invasive tools are needed, such as stereo EEG, which is actually something we have here at Memorial Hermann that is only at a few other places in the United States. And sometimes subdural grid placement and strip electrode placement is done, which is also an invasive test, and Dr. Tandon will talk about that too. The other test that we have here at Memorial Hermann that's a non-invasive test is the MEG, and that's only available in about 26 other sites in the United States, and 2 other sites in Texas at this point. That machine has been in use at Hermann Hospital in several different forms for about 20 years now, so we were one of the first sites to ever have this type of testing for epilepsy. And I won't go into the details of this test, but it can be very helpful for us in pediatric epilepsy to determine where seizures are coming from. And it gives us a different way of looking at the electrical activity of the brain in a different way from the EEG. And that can really help us to determine whether surgery is an option and to help us plan the surgery. So just a little bit about why we do epilepsy surgery. Seizure freedom in children who are not responding to medications, so their chances of responding to other medications after they've failed 2 or 3 is, as we've said, less than 2%. And so really surgery is one of the best options for those children if they're candidates, because it can result in seizure freedom for between 50 to 90% of the children who are candidates. And usually the outcome is going to be better if the epilepsy has been uncontrolled for a shorter period of time, and if all of the testing that we're doing shows that the same area is causing the seizures. And then if we can remove all of the abnormal brain tissue, you know, to the extent possible, those children have a better outcome. And then, you know, sometimes certain findings on the pathology after surgery can help predict outcome as well. So when a child is not a candidate for focal resection, so they've been seen in the epilepsy clinic, they've had all of the testing done at Children's Memorial Hermann Hospital, and they've been found to not be a candidate for resective surgery. There are still a lot of different options that they have that can improve their seizure control and improve their quality of life, and so those are all things that we can do here at Children's Memorial Hermann and at UT Health, and we do on a regular basis for those children. And that those options include the vagal nerve stimulator, which Dr. Shah will talk about, and the ketogenic diet or the modified Atkins diet, and we have actually specialty clinics in the epilepsy program at UT that are specifically for the ketogenic diet and for management of the vagal nerve stimulator device after it's been implanted in the hospital. Corpus callosotomy is another surgical procedure that can be done on children who might not be a candidate for focal resection of their the brain area that's starting seizures. And all 3 of those options, the VNS, the ketogenic diet, and the corpus callosotomy, have about a 50% chance to a 75% chance of resulting in improved seizure control for those children. And when you compare that to the chances that another medication will help reduce seizures, that's really a much better chance. So we try to pursue those options when focal surgery is not an option. So I'm going to hand the microphone over to Dr. Shah, and he will present the next portion of our presentation.
Hi, this is Manish Shah. I'm going to talk a little bit about pediatric epilepsy surgery. Following my colleague, Dr. Von Allmen, he did a great job describing exactly who we consider for surgery when it becomes medically intractable. It's a little bit about me. I went to Princeton, got my medical degree at Vanderbilt, and I completed my training at Washington St. Louis for neurosurgery and pediatric neurosurgery. one of the centers for pediatric epilepsy surgery in the country, and now I'm here at UT Houston and Children's Memorial Hermann. So we're going to talk a little bit about the surgical treatments, and my colleague Dr. Tandon is going to talk a little bit about some of the more advanced monitoring that we do that then leads to further surgical treatment. So I'm going to talk about a couple of treatments before he goes. Vagal nerve stimulation, Dr. Von Allmen talked a little bit about this for children who have refractory epilepsy. Temporal lobectomy, again, as Dr. Von Allmen was saying, if we can localize the source of the epilepsy to a part of the brain called the temporal lobe, we can take this out and have a very good chance of reducing your child's seizures or potentially completely eliminating them. Corpus callosotomy, Dr. Von Allmen was just mentioning this. This is a disconnective procedure where we disconnect the two sides of the brain to try and prevent seizures from going from one side to the other. And finally, hemispherotomy, where if we can localize all the seizures to one side of the brain, we can often get a very good chance of reducing the seizure frequency greatly in your child or potentially curing them. So the best patients for vagal nerve stimulation are patients with multiple regions of onset for their epilepsy, usually both sides of their brains. This is probably the least invasive epilepsy surgery we do. Benefits are that it's a very short outpatient procedure. It takes about an hour. It's completely reversible. We can take the generator out and the electrodes out with an even smaller surgery. And the great thing is that it can really reduce seizure frequency in certain selected patients. The risks of this procedure are pretty small. It doesn't always work. But again, not that big of a deal. We can always take it out or turn it off. There's a 1 to 2% infection risk with placing a vagal nerve stimulator in a child. This is again, pretty limited risk, as sometimes the worst thing that needs to happen is that we have to take the generator out, wash it off, and put it back in, or potentially take it out, wait for a little bit, and put it back in if it's working. And then finally, some patients do complain that their voice changes after the vagal nerve stimulation is turned on. And this is a little diagram of how the vagal nerve stimulator is put in. So here we have the pacemaker-like generator for the vagal nerve stimulator. And we make a little pocket just below the clavicle in the upper chest on the left side. And then up here we make another very small incision to find the vagal nerve, which lies between the carotid artery and the jugular vein in your child's neck. We usually wait about a week or two after the surgery to turn the stimulator on and look for a reduction in the seizure frequency. Next surgery is the temporal lobectomy. These are patients who have confirmed epilepsy originating from one temporal lobe. So as Dr. Von Allmen was saying, we have many methods of trying to figure out where the seizures in your child are originating. When all of these agree, we call that concordance. And when there's concordance, saying that there's one temporal lobe causing all the seizures in the patient, we can do a temporal lobectomy. This procedure takes a few hours. Typically, your child will spend about 2 to 3 days after surgery in the hospital. And the benefits are there's about a 70% likelihood of complete seizure freedom. This is one of the best surgeries we do for children with epilepsy, medically refractory epilepsy, when we can localize their epilepsy to the temporal lobe. The risks of this procedure, there's a small potential for limited vision loss, and there's also potential for limited language processing and speech deficits if the temporal lobectomy is done and the part of the brain or near the part of the brain where your child has some speech centers. This is a very unlikely thing to happen. So in the temporal lobectomy, little bit about the procedure itself. First, we're going to make a skin incision along the temple just in front of the ear. And that's what's been done here. Next, we're going to remove a small window of bone. That's been done right here over the temporal lobe, and this is the temporal lobe here. Next, we open the covering of the brain, and that's what's shown here. The stitches are holding the covering of the brain apart. This is called the dura. After that, in children especially, we tend to take off the tip of the temporal lobe and then start to approach the temporal horn, which is right here. And that is where we are going to identify two parts of the brain called the amygdala and the hippocampus. Often in temporal lobe seizures, the hippocampus is scarred, and we are trying to resect that tissue as well as the amygdala. And once we identify these structures using the microscope, we resect them. Next, we'll go on to corpus callosomnes. As Dr. Von Allmen was saying earlier, these patients are often ones who have drop attacks, where potentially your child has these kinds of seizures where he or she loses all their tone and falls all of a sudden. Or children who have epileptic encephalopathy, which is a condition where the seizures and the seizure frequency are to the point in the child where development is regressing and causing cognitive problems. This surgery also takes about a couple of hours, and typically your child will spend about 2 to 3 days in the hospital after surgery. The benefits of corpus callosotomy in these patient types is that it can be about 60-70% effective at stopping the drop attacks, and it can really halt the encephalopathy from progressing and potentially even give your child a chance at regaining developmental milestones. The risks of this procedure are that afterwards your child may have some difficulty coordinating tasks with both hands, new tasks that your child is going to learn. Typically, older tasks that your child has already learned, like tying shoelaces and other such things, are retained. And you can have some trouble with some complicated visuospatial tasks. This is especially true if the posterior 1/3 of the callosotomy is performed, and we're going to talk about the differences between anterior 2/3 and complete callosotomies. And sometimes they can have transient weakness and even some speech deficits. This can either be from a supplementary motor area syndrome, which is a part of the brain that can be temporarily non-functioning after retraction from the callosotomy. Usually this tends to go away. This is a color picture of what the corpus callosum is, and it's a large fiber bundle that connects both sides of the brain. And it's this big red structure here. So this is as if we were looking directly at the face in the left and the right eye. And when we color code different parts of this big, large fiber bundle, you can see that it's really a lot of it. So when we do an anterior 2/3 disconnection, we're going to be cutting through this part here. And when we do the complete callosotomy, we're going to be cutting all of this. A lot of the posterior part of the callosum we spare in higher functioning children because it will be important for them to do those visuospatial tasks that we were talking about earlier. There's lots of likely probability of them having a deficit afterwards. The procedure itself, once again, we are going to cut open the skin, this being the midline, near the midline, and we're going to make a small window of bone near the midline. And then we're going to move aside the side of the brain. Sometimes we need to use a retractor, sometimes we don't. And this is a small retractor that retracts the side of the brain. We identify the bundle called the corpus callosum, and then we cut it from the front to about 2/3, and then sometimes the entire callosum, depending again on what we've decided beforehand. So finally, I'll be talking about hemispherotomies. The patients who will do best from a hemispherotomy are those who have their seizures localized to one side of their brain, one hemisphere. These patients typically have weakness on the other side of the body, so if their left hemisphere was affected, their right side of the body would be weak, and all of their seizures would be coming from the left hemisphere. The reasons often for this can be a stroke in and around the birth period, a disease called Rasmussen's encephalitis, which is an infection of an unknown etiology that, again, only affects one hemisphere, malformations of cortical development where your child's brain didn't form correctly, and there are different kinds of this, and another disease called Sturge-Weber syndrome, which again typically tends to affect one side of the brain. After the surgery, which usually takes about 6-7 hours, typically the child will spend about 6 to 7 days in the hospital after surgery. So this is a bigger procedure, but the benefits are that there is around a 70% seizure freedom rate after surgery. It's very much dependent on what the original source and reason for why your child was having seizures from one side of the brain, but it's a great procedure when it can be localized to one hemisphere. The risks of this procedure are that temporarily these children can have increased weakness on the other side of the body. Typically they all have weakness to start with, and it usually gets a little better. And they are all going to have some degree of vision loss. We weigh these risks against the benefits of seizure freedom. So I'm just going to go over briefly what the steps are for a hemispherotomy procedure. They're a little out of order just so that when you view this webinar later, the arrows don't cross over, but you'll get the basic idea. So we first are going to resect this tissue called the operculum, both the frontal and the temporal lobe. As you can imagine, one of the most important parts of this procedure is to make sure that, since we know that all the seizures are coming from one hemisphere of the brain, is to make sure that both the tissue that we can resect and take out that's causing the seizures is taken out, and the rest of the tissue that we can't take out is disconnected and no longer able to propagate or send seizures to other parts of the brain or the other side of the brain. And so one of the next steps is an occipital-basal disconnection. And here I've shown it on the side where it hasn't been done to give you an idea of where that cut happens. Next, we do an amygdalohippocampectomy. This is part of that temporal lobe procedure, the temporal lobectomy that I was talking about earlier. And again, it's done through the temporal horn, just like previously. So that's the amygdala and the hippocampus on the side where it hasn't been taken out. Next, we do a transventricular corpus callosotomy. The ventricle is the fluid-filled chamber of the brain that's right here, and you can see the corpus callosum has been cut right there. So we do that from front to back, a complete callosotomy. And as we did an occipitobasal disconnection, now we're going to do a frontobasal disconnection, and this is where we're going to disconnect the frontal lobe of the brain from being able to propagate seizures backwards. And finally, this tissue here, the insula, is just like this cortex, except it's on the inner part of the brain, and we're going to resect that. Sometimes seizure focuses can be in there. When all those steps are done, we'll leave in a drain in the fluid-filled chambers of your child's brain to remove the debris products and blood products to minimize the risk of needing further surgery afterwards, such as a shunt. Next, we're going to move on to Dr. Tandon. He's going to talk about innovative approaches to advanced monitoring and other things we can do in pediatric epilepsy surgery. Thanks.
Hello everyone, and thanks to both Dr. Von Allmen and Dr. Shah for setting up to talk to this point. And I will speak about some of the newer approaches that we are performing, the newer techniques that we are using to help children with epilepsy. and to do so in ways that are less invasive. So as you might hope, you've seen many examples elsewhere and also maybe some today where large operations need to be done to cure the epilepsy or in some cases to localize or pinpoint where the seizures are coming from. And it has been our hope and our desire to minimize the impact on the child from such approaches. So we've made a concerted effort over the last 5 or 6 years here, and especially over the last 3 years, we've implemented a program for localizing seizures in a very minimally invasive way, and then treating the process also with a minimally invasive approach. Um, the localization approach is something that we call stereo EEG. It's a technique of being able to use electrodes that are placed through very small openings in the skull, and the resection approaches that we have include techniques of getting to areas of the brain that are deep surgically, and it's an open operation with much less impact on the surrounding brain, and also then the removal or the destruction of seizure foci using lasers. I'm not going to talk about the first one much today. We don't have much time left, but we will talk about stereo EEG and talk about laser-assisted ablations. So this is the old way of doing this. This is a child with epilepsy that we thought was coming in the left frontal lobe, was starting in the left frontal lobe. And so this child had a large craniotomy where the skull is opened and these electrodes were placed. Obviously, the question for us is, is this good? Is this good enough? Can we do any better than this? And we've been doing approaches like this for quite a long while. In fact, I compiled our experience recently in 110 patients who had 143 separate operations, 4 grid electrode placements, and actually we do very well with only one patient who had a brain hemorrhage out of these 110. And in one patient where the electrodes were removed prematurely because we thought there may be an infection. So overall, we have a less than 1% risk of any long-term consequence of neurological deficits. We did, however, notice that in patients who had previously had a craniotomy, where they'd had a surgery performed on their brain, that the risk of bleeding was much greater, almost 5-fold as great. And that makes sense because the brain is more scarred and the membranes surrounding the brain are more stuck to the brain, etc. And so this has been some of the underpinning reasons for why we have decided to consider newer options. Another important reason why we've moved towards stereo EEG at our center for many cases is that the subdural grid electrodes lay on the brain as a sheet. So as you can see here, they lay on top of the brain surface like a sheet, and they don't actually record from the deep portions of the brain. So the sulci, or the little valleys in the brain, or the deep grooves in the brain are not really recorded from. Also, the parts of the brain that lie in between the two halves of the brain, where Dr. Shah was showing you the callosotomy is done, there are many brain areas in the medial aspects, or the innermost aspects of the frontal and parietal lobes, which we cannot really easily and completely cover with grid placements. Also, when we have an idea that an epilepsy could be coming from both sides of the head, or we're not certain which side is more implicated, it's hard and carries more risk to do craniotomies on both sides to put electrodes in. And this process, for this problem of the cortex being folded and buried, is illustrated in this video now, which I'm going to play for you. As you can see, those electrodes that looked like they were closely spaced when the brain is inflated become very far and separate from each other. And there's a lot of space, a lot of real estate on the brain surface that is not actually recorded from those electrodes. And this can be represented also just as a picture. Right here, where if you see electrodes that are apparently very close to each other, here and here, end up being so far away from neighboring electrodes here. So this is the insula, a deep buried part of the brain that we don't record from. And similarly, electrodes that might be very close or joining each other here would end up on opposite sides of a deep sulcus, in this case the central sulcus. So this is really a problem with grids, and to circumvent this problem, we've started implementing a process called stereo EEG. We are actually the second center in North America to be doing stereo EEG, and it looks something like this with an X-ray. You can see that the electrodes are these very thin little probes that go into the brain at various angles, in this particular case to sample principally the right frontal lobe, but also a little bit of electrodes over the left frontal lobe in a patient where we thought that the epilepsy might be originating likely in the right frontal lobe but spreading quickly to affect the left one as well. Now, just a word about what these electrodes actually look like. This is the traditional depth electrode. It's about 1.2 to 1.3 millimeters in diameter. And then these are the SEEG electrodes that we use. They're about 0.8 millimeters in diameter, which makes their cross-sectional area less than half of the thicker electrodes, allowing them to get into very tight spaces between blood vessels in the brain, and also damaging almost no, very little tissue along the way there. So why do we use SEEG? So we've talked about some of these things already. There's less pain without a craniotomy. There's less bleeding. It's a quicker operation to put the electrodes in, and it's getting quicker as we've done more and more of them. It allows us to sample these deep brain areas, but also importantly in someone who has an abnormality that we can see on MRI scan, but we'd like to delineate the limits of that abnormality, or that abnormality is next to some important functional part of the brain. We'd like to have the ability to use stereotaxis, which is the way we know where we are in the brain relative to an MRI scan. That process is distorted, or that the brain is distorted by putting electrodes of the subdural grid variety, and is not affected by placing the SEEG electrodes. So we're still able to know exactly where we are relative to where the lesion is or where functional zones are. It's possible to sample broad brain areas, as I showed you in that case, on both sides of the brain even. There are some disadvantages though. It's harder to do brain mapping to understand where functional organization might be. And in areas of the brain like language or motor cortex, sometimes the electrodes aren't densely packed enough to really know where we need to stop. But ultimately, I think the biggest problem in this process is having a steep and long learning curve for the neurologists as well as the neurosurgeons to do this. And that is perhaps one of the reasons why this approach is not more widely used. So in our center, we have a list of what we would consider relatively optimal indications for SEEG, where there are deep malformations, epilepsy that might be originating in the insula, the cingulate cortex, medial parietal or medial frontal lobes, where it is essential to preserve stereotactic ability, where we really want a three-dimensional definition of the epileptogenic zone, and in non-lesional cases who have had prior craniotomy, in cases where we might wish to implant both hemispheres, whether it's the frontal lobes or the temporal lobes. And in epilepsies that are temporal lobe type epilepsies, sometimes even with hippocampal sclerosis, where the seizure onset and the seizure, the patient's behavior during the seizure doesn't fit with a typical temporal lobe onset. There are, of course, still patients who need and do get subdural grid electrodes, especially those who have superficial lesions where it is important to map language. So when we are concerned about the left frontal or temporal lobes, we're often putting subdural grids in it instead of putting SEEG electrodes in, because we ultimately need to have a better functional map. And in very young children, we've generally stuck to the age of 6 or older, but definitely 3 or younger is the skull is too thin to put these electrodes in. I suspect that's probably true till at least 6 or 7. So here's an example to show you all a case of stereo EEG. This is a lady who's 26-year-old lady. not a child, but a 26-year-old who had seizures though as a teenager, and the seizures comprise of her turning her head to the left side, about 4 to 6 seizures every month. She's high functioning, had a job, was working, but had failed multiple medications, and her MRI scan was completely normal. As you can see on this EEG, there is a preponderance of involvement of the right side with this EEG, more so than the left, but overall is a very generalized looking pattern with an earlier lesion on the right side. Her PET scan, which is another test that we get, as Dr. Von Allmen had said earlier, to evaluate patients with epilepsy, was unhelpful. It did not show a focal abnormality, and as I said, the MRI scan was also abnormal. This is an example of using the MEG data. Dr. Von Allmen also showed you all how we use the MEG scanner to localize interdictal spike populations. And here is, in this particular individual, the area that was most affected most early with these spikes. So this is what we did in this particular case. This is the placement of these electrodes, and as you can see, they're very small little incisions through which these probes go into the brain in various different orientations to sample the brain. And then this is the same individual's localization with of the spikes with the SEEG. As you can see, the spikes that look like they're everywhere on the brain surface actually are only in a small few focal areas with these deep recordings. This is the reconstruction of where those onsets are, and in green you can see that that's where we've represented, if you will, the population of brain cells that lead to these abnormal spikes. And in blue you can see the other electrodes that have been placed on both sides. And this is the representation of the seizure onset, and you can see where these start, and this gave us a much clearer target than any other modality that we might have used to localize the epilepsy in this difficult case, and allowed us eventually to proceed with the resection. This is the same person. This is the right side of their head. You can see the tiny little holes in the skull where the electrodes went in. And when we open the membrane covering the brain, you can see the brain is actually quite unaffected by where those electrodes went in, because the electrodes are so thin. And then this is the removal, the resection of the part of the brain that was responsible for the seizures. And this is her pathology showing that this part of the brain did not form right. Neurons are all jumbled up and pointing in different directions. They shouldn't be doing that. And that is consistent with the cortical dysplasia type 1, which is the commonest finding in these non-lesional neocortical epilepsies. So we've, over the last year and a half, had a robot to help us with placement of these electrodes, and this speeds up the placement a lot, makes it more accurate than the stereotactic frame approach, but also most importantly allows a lot of variability in how we can place these electrodes. It's very clear that the SEEG techniques have lower complication rates, and not only are they better tolerated, not only do they have these advantages of being able to sample deep areas, they have much lower complication rates, and we've done around 45 patients at this point, and our complication rates are really zero. And in the published literature, it's about 1%. We hope to do better. I wanted to also skip along to another kind of case, a different approach now of treating lesions in a minimally invasive fashion. So this is a young man who has nodules of abnormal brain cells in the occipital region of his brain on both sides. You can see them here and here. On both sides he has these nodules. This is called periventricular nodular heterotopia. We recorded many seizures from him, many seizures, and they were always consistently only coming from the left side, and that gave us the confidence in being able to put some electrodes in him. Also, he has a PET scan here, and as you can see on the PET scan, the left side is much more affected than the right. So that, along with the ictal onsets from scalp recordings, gave us the certainty that we should implant electrodes, and you can see the SEEG electrodes placed here into these deep nodules. We then localized the seizures to be coming either from the hippocampus or from the nodules. Now, in this particular person, he had good memory in that hippocampus, since we did not want to affect the hippocampus. Also, taking out this region with an open operation would almost certainly lead to pretty significant and profound and permanent visual and language deficits. So with all that in mind, we decided to go a different way, which is the placement of a very thin fiber that carries a laser probe to the target. This is the laser probe being placed in the operating room via a stereotactic head frame. You can see an X-ray that confirms here the placement of the laser fiber and at its tip. Here it is going into the head. And this is now there are two fibers placed into these into this nodule on the left side to get us a zone of ablation that would match the shape of this abnormality. And then this is the actual ablation. This is all done inside an MRI scanner to optimize the region that is destroyed, and also to make sure that regions that are important, such as in this particular individual, areas for vision, are not affected. You can see in orange here the ablation zone from one of these catheters, and with this white outline, the area that was ultimately ablated. So in our experience in our center, the optimal targets for this technique, which is called MR-guided laser interstitial thermotherapy, it's marketed by a company named Visualize. The optimal targets are periventricular nodular heterotopias, like you just saw, hypothalamic hamartomas, a hippocampal sclerosis in someone with a dominant hemisphere, usually the left hemisphere, with preserved verbal memory and fluency, and then lastly, deep-seated cortical dysplasias. So that brings me to the end. So we've touched on and talked about minimally invasive localization and minimally invasive resections for epilepsy. And to summarize, I'd like to say that these complex cases need innovative analysis and newer approaches, and cases that were previously thought of as non-surgical, such as periventricular heterotopias, can be helped with these approaches. And it takes a big group, a big collection of people, and I'm proud to have my colleagues here with me who've helped us along this journey. And at this point, we have a few minutes to take a couple of questions, maybe, and I'm going to have my colleague join us for this. So we have a couple of questions here, and the first one is, hello, if a child has hypsarrhythmia, can he still be evaluated for surgery, or is it not possible? I'm going to let Dr. Von Allmen address this one.
So in children who have hypsarrhythmia and infantile spasms, some of those children do have focal abnormalities that are causing those findings. And so we definitely evaluate those patients in the epilepsy clinic and in the hospital to see if they might be surgical candidates, and some of them are. And Dr. Tandon and I have actually done surgery on a number of those patients who are doing very well right now. So yes, I would say, it's certainly a possibility, and we do our best to evaluate those children as soon as possible. And we actually do have an infantile spasms clinic where the patients can be seen, and then they would get their workup at Hermann, at Children's Memorial Hermann.
Great, thank you, Dr. Von Allmen. The next question is from Liz Kelly, and it says, will a child be treated in the same hospital for epilepsy? I'm assuming by that you mean, are they evaluated and having surgery at the same hospital? Yes, the answer is that would all happen at Children's Memorial Hermann Hospital. And sometimes there may need to be multiple separate hospital stays for that evaluation and then the eventual treatment.
And I think, just to add, one of the great things about Children's Memorial Hermann is that we do have this big team of people in the epilepsy program. We all work at Children's Memorial Hermann, and so all of the evaluation that requires being in the hospital or getting a hospital test is done here. We can all see the results, and we all actually have a conference every Friday afternoon where we discuss all of the possible surgical cases in the children's hospital as well as on the adult side. So we really have a very comprehensive team, and it's all in the same place in the Texas Medical Center.
So we have another question from John, who wants to know, I've had epilepsy surgery and part of my right frontal lobe has had a removal. Is there anything else that can be done for my seizures? They continue, and I have about 2 to 3 seizures every night. So yeah, of course there are various things that need to be done for someone like this, especially an evaluation first with Dr. Von Allmen, including the video EEG and an MEG, and then patients are then presented in our surgery conference for eventual management and treatment. A couple more questions.
Okay, this is Dr. Von Allmen again. We have another question about genetics. How important is this in the pediatric cases? And this is something that is actually one of my favorite parts of pediatric epilepsy, is trying to understand what the causes are of a lot of the epilepsies that occur in children. And genetics has a huge role in that right now. We're certainly having kind of almost a revolution in the types of testing that can be done to look for genetic causes in a lot of pediatric problems, including epilepsy. And so most of the testing that we do for genetics and to look for genetic causes is done in the clinic at UT Health, and sometimes during the evaluation in the hospital or in other clinics at UT Health, we would consider other testing that needs to be done. And so really our approach is to look for all the possible causes and etiologies of the epilepsy in the children we take care of, because sometimes this can change what treatments will work best, whether surgery is an option or not, and really it just helps the whole group, including the family, to understand what is important in terms of the care, what might happen next for the child, and is definitely a big component of what we do when we're working up each child's epilepsy.
It's Dr. Shah. So there's a great question here. We have an international family and wondering about how we can get them evaluated. We have a wonderful international referral center here at Children's Memorial Hermann. You can give our clinic a call and we can put you in touch with them, and we'd be very happy to review your case and see what the best therapy is for your child. Thanks again.
So thank you all for joining us this afternoon, and I'd like to say thanks to everyone, Dr. Von Allmen, Dr. Shah, myself, and we hope this has been helpful for everyone, and look forward to hearing more from you and answering any more questions. Thank you.
Thanks.
Thank you, and hope to see some of you soon in the epilepsy clinic and at the hospital.